Welcome to the second live Q&A episode on female desire, arousal, and orgasm. My name is Amy, and I am the founder of Healthy Hoo-Ha. I go through the general information, and we'll go through desire, and that'll take about the hour. And then I will do a part on arousal and then a separate part on orgasm. Let's get started. I'll pull up the chat here. So we have the chat. We'll get right into the outline. We'll start off with, I don't want to go too far into shame. I have this on my outline though because there is a huge movement for hashtag orgasm gap right now. And I think that can cause a lot of people who might be having some issues with desire, arousal, or orgasm. It can put a lot of pressure on them to have an orgasm and put a lot of pressure on them to have their partner help them achieve orgasm when they might be having some sort of issue achieving orgasm. And we'll get into obviously those issues later. But I think while I absolutely agree with closing the orgasm gap, we're kind of being bombarded by it. And I think I don't want it to cause problems with people who might be experiencing issues. I don't want people who are having issues to think that there might be something wrong with them, even though they're having trouble achieving an orgasm. That doesn't mean necessarily that something is wrong with them. It's simply that there is an issue that needs resolving. So let's try to be a little less bombarding with this hashtag orgasm gap and try to make sure that if we do talk about closing the orgasm gap, that we're also making sure that people understand that it's okay if they have an issue with any of these things, the desire, the arousal, and the orgasm. It's kind of backwards there on my outline. I'll have that fixed. Desire generally comes first, and we'll get kind of into that later too, but desire generally comes first, then arousal, as arousal by definition is what is happening to the body, and then orgasm, right? So let's keep going here. There's also, with the hashtag orgasm gap, or people talking about the female orgasm, we have to keep in mind that there are a lot of cultures that, no matter what you think about these cultures and the cultural beliefs, there are some cultures that sexual pleasure, as you can see here, sorry, my nose really itches, that sexual pleasure for the female is not to be enjoyed. That it is the wifely duty and for reproduction. And while that is really, really hard for me to be okay with, it is a thing. With the cultures and religions that might have this more narrow opinion, we do have to educate the men as well as the women, because the men don't always know these things either, because they're just taught the same things. But we have to make sure to educate them that sex, regardless of whether the woman is supposed to experience pleasure or orgasm, the sex that they are having should never hurt. Should never hurt. The sex education throughout the world is terrible. My little soapbox speech here, the sex education is terrible. So regardless of what each person is believing and conducting, we have to make sure that everyone knows that it shouldn't be painful. Okay, so let's move down here a little bit. The human sexual response phases, and these are for male and female, right? These are the typical phases that each sex goes through. We have the desire and the wanting phase. And later on we'll also discuss, when there's issues with the desire and the wanting. We'll discuss when there's issues with the physical arousal. But for right now, let's just kind of go through the phases. The desire and wanting. So that's the thoughts. And the desire and wanting, I want to make a little side note, is very subjective. This one is the most difficult for scientists and the medical community to put data on because it is so subjective. We all obviously have different fantasies, different levels of desire and wanting. We all have different stressors in our life. We all have, the different lifestyles, etc. But this is typically thought of as the thoughts about sexual activity along with the behaviors aimed at obtaining sexual partners and or the sexual gratification. The excitement and arousal, which is more of the physical attributes of the phase, is the blood flow to the genitals and to the other erogenous erectile tissues, lubrication, the breast tissue in females gets lumped into this. You'll see later that there's some other places in the body that you wouldn't normally think react to arousal, but I want to save that for later. There's the plateau. Not everybody knows this word, parasympathetic. It's kind of like when you go through medical terminology course, it's kind of like the parachute, kind of like brings you down and mellows you. But that's the parasympathetic nervous system is maintaining the genital blood flow through the sexual intercourse. So it's kind of like the plateau phase is kind of just staying the course so that you stay at that level of arousal in order to get to the orgasm phase. The orgasm phase, the defining moment of euphoria, ecstasy, and pleasure in which sympathetic systems, the ones that ramp you up, move blood out of the genitals. So upon orgasm, like while you are feeling all those pulses, your body is also simultaneously trying to return itself back to normal, like immediately. It doesn't necessarily happen immediately, but it happens very, very quickly. Then you have the resolution phase. So this is where people, the refractory, like it says there. So we have a lot of systems in our body that create inhibitory reactions so that our body kind of goes back down to that rest period. This is where a lot of time where females will be, sometimes they can get a little bit tired. I know we joke about men kind of getting tired and wanting a sandwich after, but it also happens to women a lot of the time too. We just seem to get a little more snuggly. We might want to take a nap. And I apologize. I do my best to be inclusive, but I will automatically just go back and forth between women and females, and sometimes I'll mention biological females. It's a thing we all in the community, in the medical community, have to try to train our brains into using vocabulary, because we had a vocabulary for so long and we want to be inclusive, but sometimes when you get up a little bit older, especially I'm about 40 now, I've had 25 years, 30 years of calling the female sex women. So I don't mean to not be inclusive. It's kind of just like a retraining of the brain. So please keep that in mind when you hear me say women. If you're not identifying as a woman, but you have female sexual parts. Okay, thanks. So we'll move on. The psychological reasons for desire or arousal disorders. I get a little bit more in depth into these things when we come to the desire and arousal sections. But in general, throughout all of the episodes, I won't get very deep into much of these, as they are their own health issues, right? Like I'm not going to go through depression and anxiety very in depth on a female sexual health recording. Psychological reasons for desire and arousal disorders. So there's more than this, but these are the biggies. So depression and anxiety are big ones. If your body and your brain is trying to overcome these things listed, it's not going to be able to function sexually very well, because that is one of the easiest things for the body to basically dump off to the side while it's trying to fix other areas of itself. Body image is going to be another big one. If you hate the way that you look, you're not going to be able to focus on the good things that are happening to you during a sexual encounter, or you're not going to want to put yourself in those positions. And so that's really going to start affecting your ability to have innate desire or responsive arousal. Environmental stressors. Hello, COVID. There has been a massive amount of research done this year surveying people on how COVID's been affecting them. But even before COVID hit, whether you were sick or you had money trouble or you had family health trouble or a fight with a sibling or whatever it was, any of these stressors, even though they might not cause depression or anxiety long term, they are causing it short term. And so your body wants to fix that before it's able to be sexual. And this mostly pertains to females. There is some root in when you hear the stereotype that men use sex to relieve stress and women have to relieve their stress before they can have sex. There is some root to that. Obviously, it's not about every single person, but the stereotypes and the roots come from somewhere, and that's because there's a pattern a lot of time, and so a lot of times women have to relieve their stress in order to be sexual. Then, like I said earlier, the cultural and or religion aspects. If you're in a culture or religion where your female desire, arousal, and sexual satisfaction is not a priority, or it's seen as something that is shameful and shouldn't happen, that's really going to affect how you are functioning in that department. Relational factors. If you're having sexual abuse or relationship abuse or domestic abuse, kind of the same thing. If you're having poor communication about what your needs are, the sexual dysfunction suffered by another partner is one that they're finding as well. Is if your partner is suffering with sexual dysfunction, that a lot of times is showing that it's leading you to not want to initiate because you feel bad. You feel bad that your partner is having issues, so you don't initiate. If your partner initiates and things end up not going very well, all of these things are training your brain to... I just realized that my mic isn't on me, so I am terribly, terribly sorry if that was really quiet. It should hopefully get much louder now. I put the mic where it belongs. This is what happens when you go live. But anyway, as I was saying, so if your partner's sexual dysfunction is something that's happening, it can cause your brain to... Thank you, Kate. I don't know why. People never bring things up right away. But it can cause your brain to not, want to be sexual, because every time you are sexual, something bad is happening. And so it's kind of a training of the brain. Health and lifespan considerations. Pregnancy, hormones are all over the place. Some women can get more sexual, others get very turned off. Infertility. If you are trying to get pregnant, let me keep the hair off the mic. If you're trying to get pregnant and it's not going well, you get very frustrated. Doesn't make you want to have sex. If you're trying all the time, it becomes very mechanical. You don't want to have sex. Aging and menopause. Obviously, the hormones are changing there. And we will get into some of that obviously later. But with aging and menopause, the testosterone and estrogen specifically are basically in the shitter. And so you're not getting that desire, and you're also not getting a lot of the physical arousal that you need to have great sex or even okay sex. The metabolic syndromes, I need to scroll down a little bit here. The metabolic syndromes, things like diabetes, obesity, high cholesterol, hypertension, the glucose, impaired glucose you see there, even if that isn't diabetes related, if you have things like hypoglycemia that doesn't give you necessarily a diagnosis of diabetes, but if you're not making sure that your blood glucose is remaining stable, it's another one of those things where your body is trying to fix other parts before it wants to be sexual. Cancer, obviously a big one. You might want to be close and intimate with your partner, but during cancer and cancer treatments, sex is one of the first things to go. The removal of the sexual hormones. So things like hormonal oral contraceptives, or if you take something like a hormone blocker, these are going to significantly reduce your sex drive, your ability to become sexually aroused, and possibly your orgasms. There's a huge debate with hormonal oral contraceptives about whether it stunts the sexual functioning or not, because there are reports on both sides. This is something I'm going to be writing about later in a good book that kind of explains all of that. This is Your Brain on Birth Control by Sarah E. Hill, I believe. Anyway, oral contraceptives and hormone blockers can significantly reduce all of the stages of the sexual phases. Short vagina barrel issues. There is a wonderful woman, I can't remember her name, that I met at a conference that I was at, and she had conducted a study. She had this neat little like rubbery stopper thing, and it's called O-Nut, OHNUT. Look it up, it's fabulous. So while the vagina is not terribly long to begin with, we'll see later that it does lengthen and widen. There's been some Bad Women's Anatomy posts about men's view of what happens with the vagina. But anyway, there is also such a thing as a short vagina barrel. And so even if you have an average sized penis, sex can be incredibly difficult for women who might have a shorter barrel because it just runs out of room. Otherwise, you can also use it with a above average sized penis, or even some of the much larger penises on a vagina that doesn't have a short barrel issue. This O-Nut is fabulous. I recommend you check it out. It's this like rubbery donut thing that you put on the base of the penis. And so when you're having sex, if you are a couple that is having length inconsistencies between the penis and the vagina and you're running out of room, this O-Nut donut can help. Here's my little plug. Not for my product, for somebody else's. The vagina barrel can become damaged due to childbirth. This is another thing that can affect your sexual desire and arousal. The damage from childbirth is usually from rips and tears, as you can see there. Some damage to the pelvic floor muscles causing laxity. This doesn't equate to a loose vagina. There might be a little bit more laxity, but we will see later, and I will say right now, that during arousal, the orgasm platform basically tightens up the vagina on the outer third, about a third of the circumference. So even if you're having a little bit of laxity or damaged pelvic floor muscle issues, this does not equate to a loose vagina, as can be thought of a lot of times and posted in Bad Women's Anatomy. So we'll just make sure that that's clear right there. Another thing that can cause some issue with sexual function is the pelvic floor muscles and or pelvic floor nerve problems. These are massive and will be its own topic that I write about because it affects an enormous amount of a female and male's sexual function. And a lot of the things that the pelvic floor muscles and nerves do, we don't realize that they do to our sexual function until someone tells us, because obviously we're not taught any of these things in school or sexual education or anything, or anything like that by the doctors, unless it's a doctor or a specialist that you go to see. So these muscles and these nerves are significant in our function. Something called and I'm going to pull up some visual aids here, so I may or may not be hidden by my visual aids, but I am here, don't worry. The transverse perineum trigger points can cause something called dyspareunia, and that's basically just painful sex. So let me pull that one up here. We have, my mouse, come on mouse. I have perineal muscles here I'm going to pull up. So hopefully this is big enough for you. Otherwise you can just Google images for the perineum muscles and nerves and things like that. But you can see all these muscles all around all of our bits. If any one of these is tight or pissed off, it's going to affect how all of our bits work, because they're all interconnected. As you can see, all of this goes around the vagina and the clitoris. It goes around the butt muscles and the anus. There's the muscles all around here and ligaments and things, and it's all connected. If any one of these is pissed off, you can have some sexual dysfunction. The pudendal nerve that's listed next on the outline, this one's much harder to read. Obviously it's very small, but the main purpose that I wanted you to see here is where all of these nerves and blood flow are going to. Here is the clitoris, the urethra, and the vagina. So you can see all of these nerves and all of the blood, well, a lot of the blood flow, but this is mostly nerves. There are some, it does say some arteries here. But again, these things are all very interconnected, and so they are significant to our sexual functioning. If any one of these nerves is pissed off, there can be significant decline in sexual functioning. There can even it can cause itching, just like uncontrolled itching. You're like, what the hell is going on? I can't, things won't stop itching. Well, it's a lot of times one of these nerves in the pelvic floor. Another thing that can happen is pain can also occur during post-orgasm due to the contraction of a dysfunctional muscle or irritated nerve. So you might be able to have sex just fine, and then you have an orgasm, and now your whole like vulva area hurts, and you're like, what? That contraction during orgasm could very well have cramped a muscle or pinched a nerve. Yay! So if things don't get better, obviously see a medical professional, and I can put some links. There can be an orgasm, which is no orgasm. It's just, well, it's no orgasm. It's just a fancy term for no orgasm. Due to the inability to allow the myotonia, which is the muscle, the muscle tension. I have it later on what that means. So I'm sorry if I'm wrong about that, but it's basically the muscle tension. So the inability to allow the muscle tension and thus the resulting muscle spasm once the muscle tension threshold has been reached. So as the orgasm builds, if you know that you haven't had an orgasm, you'll know that the muscles kind of there's more tension and more tension and more tension in them. But if there is a malfunction, so the nerve fibers in the muscle reach a certain plateau, push you over the edge, contract, then you get the refractory period, right? But in orgasm, if that process has a malfunction, you won't reach over that hump. So you'll have the muscle tension, but it won't get over that hump to start contracting. You could have clitoral pain due to the pain from the pelvic floor, muscles, or nerve, hypersensitivity. So there are a lot of people who have clitoral pain, whether it's all the time. They could have clitoral pain during arousal, and during stimulation, during orgasm. They could have it throughout the whole thing. It's usually due to a pelvic floor muscle or nerve. Sometimes it's due to an infection they're unaware that they're having, but it's usually due to the pelvic floor. Another part of the pelvic floor that can cause sexual dysfunctioning is urinary urgency, frequency, or burning due to the friction of the urethra and surrounding tissues, or referred pain from the pelvic floor, pelvic girdle, or abdominal muscles. This is different from something called the bride's cystitis that I'll mention later. So it's very, very similar, but just enough different. So the pelvic floor can still have the friction along the urethra during sex, but it includes all those surrounding structures, like it says there, the pelvic floor and the pelvic girdle or abdominal muscles. Another thing that can cause the tissue or the sexual dysfunction is the tissue's responses to androgens may vary. So a lot of times I counsel women who say, well, I'm not in menopause, or and so my hormones should be fine, or they were able to get their hormones tested and their blood levels of hormones were fine. So like it says right here, so your doctor running a blood test and saying you're fine when you're having painful sex needs to be further investigated, because what is happening a lot of times is that just because your blood levels say that your hormones are fine, and this isn't in every case, I don't want you running off to your doctor and saying healthy hoo-ha said that my vulvovaginal hormones were low. There's other things that go into it, and that's why seeing a specialist about these things, they'll be able to look at everything that's happening and determine whether this isn't something you can test for. The blood levels are not an accurate picture of what's happening at the tissues. The receptors in your vulvovaginal tissues could be malfunctioning and not utilizing the testosterone and or estrogen that your body is producing. And so you might have fine blood levels of the testosterone and estrogen. You might have normal levels of SHBG, sex hormone binding globulin. That may be in normal ranges. You might have normal ranges of everything, yet you are still having vulvovaginal issues. And this is where the specialist will come in and say, okay, well, let's look at everything. And let's try some things. It could just be that your tissues, the receptors in those tissues are not utilizing the hormones. And so you're going to have painful sex. You're going to have more urinary urgency. You're going to have dryness and irritation problems. So this is something to consider and something to have a conversation with your doctor. I always tell people that I counsel to have these conversations, take this knowledge and have a conversation. Don't go in there and say, I need this, I want this, this is what you need to do, because they're just going to shut down, because they want to work with you. You can't go in and demand things. The medications, a lot of medications will cause sexual side effects, specifically SSRIs. Now, not everyone has a problem with SSRIs. Not everyone has the horrible horror stories that you see online. But SSRIs are the most common antidepressant and anti-anxiety to cause sexual side effects, mostly because of how they work. They keep serotonin floating around longer. And that's going to affect the dopamine and norepinephrine levels, two things that you need for sexual functioning. We will see later in further episodes that the dopamine and norepinephrine, which are stimulants, very important to sexual functioning. Serotonin is very important to the come down. And so if you've got a lot of come down chemical floating around and not enough of the arousal chemicals floating around, you can guess what's going to happen. Medications to treat high blood pressure. So these affect how the smooth muscle relaxation is functioning. And so the clitoris is very similar to a penis, not exactly, but it's very similar. They both have the blood tubes, to put it extremely simply. They both have blood tubes inside the shaft. And those tubes need to relax in order to allow the blood to flow into the tube. And the clitoris becoming filled with blood and erect is a significant part of how the woman gets to an orgasm. So antihypertensive medications can affect how the clitoris reacts. Anti-epileptics, as you can see here, many cause, not all of them, but there are many of them that cause lowered bioactive testosterone. Females need testosterone, a very, very tiny amount, but we need it. It provides vulvar lubrication for the most part. It does very little for vaginal lubrication. It provides lubrication and moisture to the vulva and the vulvovaginal opening. Estrogen is the main component that provides vaginal lubrication, but testosterone ultimately gets converted to estrogen. Messing with either one of those, taking any medication that messes with either one of those, going to cause you issues. Testosterone is also a proponent in females' desire. Hormonal birth controls. Not only do they reduce the sex hormones, regardless of how a female feels while taking hormonal birth control, regardless of whether she notices a lowered sex drive or notices an increased sex drive, regardless of these things, hormonal birth control, it is a fact that it reduces sex hormones. It has to do these in order to prevent pregnancy. So that should end that aspect of the debate right there. In order for hormonal birth control to prevent pregnancy, it must reduce the sex hormones. And then it provides you with a set of false hormone, these fake hormones. They aren't utilized by your vulvovaginal parts for sexual functioning. And the way that they real quickly prevent pregnancy is they keep the receptors between the HPO axis, believing that the estrogen and progesterone are high. So the brain says these hormones are high, and it sends a signal down to the ovaries to stop producing what it needs to make an egg. Okay? That's extremely basic of how that works, but it reduces the sex hormones and then raises SHBG, sex hormone binding globulin. So any amount of natural estrogen, testosterone, and progesterone you are making through taking the birth control a lot of times gets gobbled up by the sex hormone binding globulin. And so your vulva and vagina aren't really left with anything to function properly. Antipsychotics affect sexual function mostly by elevating prolactin levels. And this is produced during to create milk in the breast. And if you are actively creating milk in the breast, your body does not want to make another baby. Okay? It's doing things to prevent you from making another baby. You're nursing one already. I'm not going to get too far into that one, but it does show that antipsychotics, a lot of them are raising the prolactin levels. Cholesterol lowering medications, some of them, not all, some can lower testosterone. It's mostly being found in males that it's doing this, but there have been some reports in women, and so I just wanted to make sure to cover. Some antihistamines, mostly Benadryl, and I want to say there was another one, I can't remember what it is, you can Google it, but there are a couple of antihistamines that can cause vaginal dryness and can affect how well the clitoris, corpus cavernosum, those are those tubes. Here I can pull that up really quickly and just show you that. Is it this one? Yep. So if you see here, these two little tubes, the corpus cavernosum is what fills with blood. The antihistamines can affect how well those tubes soak up the blood. Opioid drugs. Not going to do any shaming. Just know that if you are taking any opioids or any drugs like heroin, which is basically an opioid, or I don't really do these things, so I don't really know them all, but they will decrease androgens and testosterone, especially in long-term use. Short-term use, sometimes they're prescribed for very significant pain relief, obviously. So there's no shaming, whatever. Just know that they can do this. They can decrease the androgens and testosterone. Glucocorticoids, which are steroids. You might have these injected into like a knee joint or a back joint, or you can have them applied to the skin for various reasons. There's a lot of applications for glucocorticoids and steroids, but they lower free, serum, and bioavailable testosterone. They do it to everyone, but to variable degrees. Okay, so one person might be fine, another person might be super sensitive and be like, I had that injection and now I don't want my partner to even look at me. Tagamet, which is I think that's a stomach acid blocker. I believe so. But that works by blocking something called H2 histamines in the stomach. But these H2 and the histamines also affect the corpus cavernosum. The other ones don't have, that I can find any reporting of doing this. That's why it's called out Tagamet specifically. I don't want to cause any ill harm to their sales, but this, it's really available on the internet if you type this stuff in. Alcohol. While alcohol does make you want to have sex a lot of times because it reduces your inhibitions, ultimately, behind the scenes, behind that curtain, it is inhibiting the hypothalamus pituitary gonad axis. The HPG axis, sometimes referred to as the HPO axis in females, the O being ovaries, but it reduces the release of gonadotropins, which are sex steroid stimulators. So it reduces the release of those from the pituitary, thus reducing the androgens, which are how our progesterone and testosterone are created, and then ultimately our estrogen. THC. This is another thing that you have half the population saying that it makes sex better, makes them want to have sex, and half the population says it gives them anxiety. Well, it does both. It will make a certain portion of the population have the increased sex drive and better sex, and it will make that portion of the population who experience anxiety. That's based on how your brain's receptors function. I wrote an article about how THC and estrogen intermingle. It can give you cotton vagina just because it dries out the tissues for some people. Essentially, THC stimulates the endocannabinoid system. It's how you get high. Well, the stimulation of the endocannabinoid system on the HPO axis attenuates, which means it dampens down the flow of hormones and flow of sex hormones, and it dampers down dopamine fluctuations needed to stimulate desire and arousal. We have something called non-concordant, meaning that our body can behave in a certain way in disagreement with our mind. Okay, we can be experiencing sexual stimulation in our mind and have our bodies not respond, and vice versa, such as in the case of sexual assault. Our brains can want to have sex. This is where the desire, right? It wants to have sex, and our body doesn't cooperate. That's non-concordant. Orgasm and arousal can cause a phenomenon of chemical reactions that solidify the memory connection. So the orgasm during a traumatic sexual encounter does not indicate you were having fun. Arousal and lubrication during sexual assault does not indicate you were enjoying the event. Our body is simply reacting to previous muscle memory and chemical reactions due to the adrenaline. We can have these same reactions during exercise. A lot of times women will report that after physical exercise, their vagina is wet or lubricated. They may be aroused. Some women have even gone so far as to experience orgasm because of adrenaline. It's simply because of the adrenaline and the dopamine that gets released during these bouts of adrenaline or exercise, which then ultimately results in the release of the opioid, which is the happy chemical. Okay, sex, even a one-night stand, to your body and your brain and your learning centers, sex is never just sex. Okay, my little outline on my little screen here, so I know what's going on, is kind of small, and so it's kind of hard for me to see what I'm reading. That's why I keep looking back at my bigger screen. But yeah, to your brain's learning center, sex is never just sex. Okay, so oxytocin is excreted simultaneously during sexual intercourse between both sexual partners. Okay, you can see that. The parallel release of oxytocin reinforces the sexual arousal of both parties and is associated with affiliative, non-aggressive behavior, favoring the formation of pair bonding. This is something that we have a lot of trouble getting hard data on. Scientists suspect that we can smell oxytocin. It's kind of cool, but it's something that we can't really pin down. And this, I think, is where the parallel release of oxytocin during a sexual encounter comes from, is because we can smell it. This is where they think the mother and child during nursing bond gets reinforced, is because it's being smelled. The oxytocin plays an important role in sexual responsiveness, arousal, and orgasm. It's not just something that is secreted during a mother-infant situation. So while we are able to have one-night stands and move on, or have a relationship and move on, or maybe just even casually date somebody, our learning centers don't see sex as just sex because of the oxytocin. Plain and simple. The oxytocin gets released, we smell it between each other, and a very, very small to a large amount of pair bonding formation happens. I used to joke that if I had sex with somebody when I was younger, before I was married, that even after breaking up, or even if it was just a one-night stand, if I thought about that person having sex with somebody else, there was a little bit of jealousy. I would feel territorial. Not because there was necessarily any kind of like emotional connection or desire to be with that person, but because I peed on that. That was mine, because the pair bonding. But I am also very sensitive to those kinds of things. Not everybody is. Sometimes people don't experience this pair bonding. Maybe they don't smell the oxytocin from somebody as much, or they're not putting off as much. To wrap that up, your brain's learning center doesn't see sex as just sex. Desire is a psychological interest in sex and one's willingness to work for sexual reinforcers. That is the definition. It is very subjective, so it's hard to get data on this. We are all very different. When we answer questions about these things, it's not something that we can put a probe into or a monitor on or put an image to. It's in our brain. Not only do we all have different brains, obviously, but we all have different ways of expressing how we feel things are happening. So even if a group of people are experiencing the same exact thing, we might all express it verbally differently. So it's very hard to put data and desire. But we do know some things, and so that's what I'm going to be going over. As much as we know currently. So we have what's called an excitatory and an inhibitory system, which competes for control. Our body, the desire, our sexual desire, is the balance between the excitatory and inhibitory systems. The excitatory system is the dopamine, the estrogen, testosterone, and norepinephrine mainly. There may be, that we're not quite aware of right now, other chemicals, but this is what the main parts are: the dopamine, estrogen, testosterone, and norepinephrine. The inhibitory systems are the serotonin, the progesterone, prolactin, and GABA. Okay. The brain must balance these excitatory and inhibitory influences to achieve an optimal level for pleasure. It must do this with hormonal influences weighing it towards excitation. So the hormonal influences want us to have excitation, want us to have sex, especially during ovulation. I don't get too far into ovulation in any of the episodes, but it is things that I talk about a lot on social media and Reddit. Ovulation is a time of the menstrual cycle where the hormone influences want you to seek sex, have sex, and so it's weighing it towards excitation, and the experience directing attention and behavior toward individuals and stimuli previously associated with sexual reward. So we've got one part of our body that wants to seek out sex, and then another part of our body, or our brain chemistry, that wants to increase the inhibitory influences so that we are mellow and doing other things with our lives, right? Because our brain knows that we can't just sit and have sex all the time. And so we need that inhibitory influence in order to get other things done. Dopamine, which is one of the excitatory system, part of the excitatory system, is what drives us to seek positive outcome or reward. It is not the happy chemical. A lot of times people mistake dopamine as the reward chemical being released, but that is in fact the opioids. Dopamine is the chemical that causes us to seek the reward. Dopamine is the reward. Dopamine is increased by estrogen, hence why during ovulation, when estrogen is very high and not inhibited, makes you want to have sex. Prolactin also has an effect on dopamine in different ways and in different parts of the brain. So hyperprolactemia causes too much dopamine, which leads to the suppression of gonadotropin releasing hormone. I think I got that right. Sometimes I don't get the acronyms right. Which also, when the hyperprolactemia, which is causing too much dopamine, that ultimately leads to a decrease in the HPO axis's function and stimulation of the sex hormones. Because remember, we want to maintain homeostasis. So if one thing is getting too high, our homeostasis mechanisms cause the other systems to then cause homeostasis. So the dopamine is getting too high, and it is leading to the suppression. So okay, let me back up just a second. It's all very complicated. Dopamine gets really high. The endocannabinoid system says, "Whoa, too high, too much." The endocannabinoid system tells the HPO axis. Let me pull that up really quick. That I have a little diagram for that. So the HPO axis says, calm down on the GnRH, the gonadal releasing hormone. It says, calm it down. We have too much going on. We have too high levels of this, or we have too high. So not only can dopamine make this HPO axis do these things, but too high of estrogen, too high of testosterone, too high of progesterone, too high of all of these things, or too low. Okay, there's a negative and a positive. There's a feedback system, but too high of these things will lead the endocannabinoid system to tell this little diagram here that you see to calm things down. And so it says, calm down the GnRH, which tells the pituitary to calm down the LH and FSH, which tells the ovaries to calm down production of testosterone, estrogen, and progesterone. Okay? So let me go back to the outline. The reduction from the HPO axis function and a cascading effect on the sexual health and response from reduced ovarian production of sex steroids. And that's why when the prolactin is high for like breastfeeding, or if there's a malfunction, as males can also have high prolactin, and it will affect their sexual functioning as well. But that's why when you have the high prolactin during breastfeeding, your body, it's basically a natural birth control, because it's telling the endocannabinoid system to tell the HPO, to tell the pituitary, to tell the ovaries to shut down production. We'll also discuss prolactin later in the orgasm section, but prolactin is increased immediately after orgasm. It's that inhibitory and refractory portion of the sexual response phases. Serotonin is massive, and actually, I want to say over 75% of it is in our intestines. I think I got the percentage right. I may have gotten it wrong, but we'll just go with most. Most of the serotonin is actually in your intestines. So serotonin is a massive world in of itself. Okay, so we're only going to touch on it, and I'm only going to put things super simply. But super simply put for this episode, serotonin is increased by progesterone. Progesterone and serotonin are an inhibitory. GABA is also increased by progesterone. GABA is a chemical that makes you sleepy and mellow. So you will see that both serotonin and GABA makes us calmer, more mushy individuals instead of the excited and driven to reproduce individuals, as serotonin is part of the inhibitory system. Desire and vaginal response to erotic stimuli is increased in women with high testosterone levels. We're not quite fully sure if it's the testosterone itself, if it's because the testosterone, the testosterone is significantly linked to a woman's libido and desire, but scientists and studies are not able to definitively determine if it is due to the testosterone itself, or that when it is low, thus so is estrogen low, as testosterone is aromatase turns into estrogen, or if it is a combination of both sex steroids. Based on the data, it looks as though it is due to both hormones, simply due to the testing we have done on levels, but the exact mechanism is still unknown. Testosterone alone does not create a fully functioning sexual ability, and neither does just estrogen. We need them both. We're just not quite sure why, because obviously the testosterone does one thing or some things, and estrogen does some things, but without them both, we don't have a full picture, right? Okay, So combined supplementation with estrogen and androgens promoted sexual desire, sexual arousal, and increased numbers of fantasies versus estradiol alone. So even though testosterone is turned into estrogen, we still need the testosterone to be the whole picture. Testosterone alone significantly made better both sexual desire and satisfying sexual activity, and 6 weeks of estradiol was associated with global increases in the brain for erotic and neutral stimuli. So mostly for menopausal women, but for those lucky few who get their doctors to acknowledge the fact that they're having problems at a young age, testosterone is given for low desire in females. Females that were only given testosterone did not have the same effect as when they were given testosterone and estrogen. It's so complicated, and we are just now, in the last couple of decades, even been given the funding or the interest to conduct studies and look into any of this, and so it's still all very new. Estradiol plus testosterone was associated with higher activation in the limbic system. The limbic system is the part of the brain involved in our behavioral and emotional responses, especially when it comes to behaviors we need for surviving, feeding, reproduction, and caring for our young, and fight or flight responses. So you can see where you need both of them to, like I keep saying, to have the whole picture. Additionally, a significant incidence of masturbatory activity or wanting to have an orgasm, even if you don't want to masturbate, you have a partner and you want them to help you with an orgasm, corresponds with the mid-cycle peak of androgens. So mid-cycle for a female, both testosterone and estrogen are peaking without the attenuation, of progesterone. So a little side note, in the luteal phase, closer to the period, the menstruation period, progesterone peaks about day 21 on average. But so does estrogen. Estrogen peaks twice in the menstrual cycle. The reason why a lot of people say that estrogen is low during this phase is because they've clearly never seen a hormonal cycle on a graph. I'm blunt, you'll come to learn that. But they also don't quite understand how the hormones work. So during the luteal phase, around day 21, as I was mentioning, both estrogen and progesterone are peaking. But progesterone inhibits the effects of estrogen. It does not inhibit estrogen itself. It inhibits the effects estrogen has on the body, which is why we don't get 2 peaks of wanting to reproduce. We just get the one mid-cycle during ovulation. Additionally, a significant I was thinking about the mid-cycle peak of masturbatories, because when the estrogen and testosterone are high in mid-cycle, we want to not only reproduce and make babies, but we're getting a lot of blood flow and nerve stimulation and chemical stimulation, driving us to have sex. Sexual desire and female-initiated sexual behavior change across the menstrual cycle with a peak during the fertile phase. Such variation across the cycle is not observed in women using oral contraceptives, because you're suppressing your natural hormones, but the sexual desire, female-initiated, that's the key word, is the initiated sexual behavior will change across the menstrual cycle. Generally, during the mid-cycle peak of hormones, females have spontaneous desire and arousal because those hormones are high. They're driving us to copulate. During the luteal phase, a lot of women might just say no to sex altogether. They're bloated, they don't feel well, they're cranky, that whole spiel, right? But a lot of times we have, during the luteal phase, what's called a responsive sexual response, a responsive sexual response. And it's when your partner wants to have sex and kind of like test the waters. They touch you a little bit in innocuous places. They might rub your shoulders. They might give you a look. They might slap your ass and kind of test the waters and see how things are going. If you respond, they go a little bit further. If you keep responding, they go a little bit further. Next thing you know, you're in the luteal phase, you're bloated, you feel like crap, but you still want to have sex because that initial testing the waters sparked your brain and your body to be like, yeah, you know what? I think I want to have sex. So the evidence that the androgens are important modulators of women's sexual function stems mainly from the studies of testosterone therapy given to postmenopausal women. Conditions associated with low testosterone. Spironolactone, a common acne medication. It's an androgen blocker. And that's how it works as an acne medication. Testosterone and other androgens can cause acne. There's other reasons too, like inflammation and dairy allergies and things like that. But testosterone and androgens can cause acne. That's how spironolactone works, is it blocks the androgens. Well, if you're blocking the androgens, you can imagine what's happening to your vagina and your vulva. The androgen blockers for transgender people. Unfortunately, not enough transgender people who seek androgen blockers are getting all of the information about the medications that they are seeking. And so they get put on androgen blockers, and then they start having sexual function problems. And they don't know why. Glucocorticoid therapy, like I mentioned above, hormonal birth control, is associated with low testosterone because of the high SHBG. Anorexia will cause low testosterone, and POI, which is primary ovarian insufficiency. Causes for low estrogen. In case it wasn't clear, that the low testosterone and low estrogen are going to be significant reasons why you don't have desire. Also arousal and orgasm, because they're all interplayed, but they're going to be reasons why you don't have desire. Causes for low estrogen: hormonal birth control, the POI, the primary ovarian insufficiency, excessive exercising. Other eating disorders besides anorexia, such as bulimia, maybe some binge eating, and a couple of various other health conditions. There is some issue with PCOS, things like diabetes and obesity, because of how the estrogen is stored in the fat cells, things like that. Another thing about desire is a small degree of stress or threat in humans can be arousing. So you think of something naughty or mildly painful, can be arousing for a lot of people with low levels of arousability, or just anybody. But for people with low arousability, those stressors or threats, perceived threats, kind of like a threat fantasy, can really help somebody with low desire, because it's that adrenaline factor I mentioned earlier. Translated to a sexual situation, such arousal could be directed into sexual activity, perhaps to the point in some individuals that it becomes a necessary antecedent, so basically necessary. Anger, fear, or even short-lived terror can be a prelude to sex specifically because it stirs passion or arousal that leads to an excitation transfer into sexual excitement under the right circumstances. So the adrenaline is going to spike that excitatory, I can't think of the word, the excitation. It's going to, stimulate the excitation. This is many times where fantasies about rape or home invasion comes from. Many people feel ashamed that they are turned on by these thoughts or fantasies, but it's typically due to the fear, excitement, adrenaline aspect, so don't ever feel bad if that's something that you like to fantasize about. As long as it stays a fantasy, and as long as it's not harming you or anyone else, and it's not becoming a problem, it's just a fantasy. And if you're having trouble with low desire, use what you got. It is generally accepted that the steroid hormone actions in the medial-basal, hypothalamus, and limbic system prime the brain to be selectively responsive to sexual incentives. Such priming involves molecular actions that result from the binding of androgens, estrogens, and progestins to specific hormone receptors and that lead to the synthesis of different neurotransmitters and the transmitter receptors. This creates a neurochemical state in which sexual stimuli are attended to selectively and are more likely to induce sexual responding. Which is why many naturally menstruating or normally cycling females will report that their sexual desire rises steadily in the week prior to ovulation and peaks around the time of ovulation, only to be followed by a precipitous decline over the subsequent week. Very generally, this is what I mentioned earlier, where when the testosterone and estrogen rise mid-cycle, you're more sexually stimulated because your receptors are being primed and lock and keyed more. I mentioned this little bit earlier. Here's where this comes into play as a spontaneous versus responsive desire. There are narratives where humans can be either the initiator, which typically is what happens during mid-cycle ovulation, due to having an endogenous desire and arousal, but we can also become turned on due to a partner attempting to engage in sexual events. Both of these narratives are okay and consensual and normal. Sometimes we want to be intimate with a person, but our hormones, especially females, due to our cycles, aren't in a place where the hormones are initiating the desire or arousal without having some prompting. Having one of the medical conditions or one of the medications that I mentioned earlier, or having a sexual dysfunction or desire dysfunction obviously plays a role into this. I wanted to go over how the HPG axis works, and I'm going to pull it up again. I know we went over it before, but I want to go over it really, really quickly. So the hypothalamus stimulates basically a chemical. I mean, the hormones are chemicals too, but it's basically a chemical, GnRH, which then stimulates the pituitaries to then stimulate the luteinizing hormone and the follicle stimulating hormone, which happen at different times of the month. LH and FSH can do overlap, but for very narrow spot to promote the release of the egg. But the LH and the FSH prompt the ovaries to do what the ovaries are supposed to do. The ovaries then create the estrogen and progesterone, which then provide the negative feedback to the pituitary and hypothalamus. If one of these parts aren't functioning properly, this can have an effect on desire. But this is also partly how desire, works, is by getting the proper amount of sexual steroids produced and then negatively fed back to the hypothalamus and pituitary. Sexual experience allows us to form instrumental and Pavlovian associations that predict sexual outcomes and thereby direct the strength of our sexual response. Meaning that if we have good sexual encounters, our brain, it's getting really hard for me to look at the little text on my live stream screen because it's getting late and my eyes are getting old and tired, so I keep having to look at my big screen more and more. I'm really sorry. But it basically means that if we have good sexual encounters, our brains put that in the memory bank. And when a sexual situation arises, the dopamine drives us to seek the reward of another successful sexual encounter. Or in the case of when dopamine is too high, such as the mid-cycle, the dopamine will cause us to start a sexual encounter. Then the opposite is also true with either a negative or multiple negative sexual encounters or the extreme of sexual abuse or assault. The brain learns. If it learns sex is good, it will cause you to seek it out. It will cause the desire. It will cause desire to start in the brain, then to start in, the sexual bits that we all have, right? But it learns. If it learns that sex is good, it will cause you to seek it out. If it learns that sex is bad, it will prevent you from having desire, for as it doesn't see that there is a reward. The brain also has to choose between different drives and motivations. Due to hormones and other neurochemicals floating around the excitatory system is driving you to copulate from the bottom up. So the excitatory system is going to cause more blood flow to the genitals, which, like during mid-cycle, you might notice that your genitals are aroused before your brain even realized that it wanted to have sex. And now all of a sudden you want to have sex and you're like, whoa, okay. But that's a bottom up. And so and then the inhibitory system is using executive function in the brain and reasoning to inhibit you from copulating from the top down. And so that's where that balance is the excitatory is like, no, I want to reproduce. And then your brain's like, but I have to like work. And so, or I, have to go pick up the kid, or I have to go grocery shopping. And so I can't have sex right now. And so you're going to have to know, do we eat or do we have sex? Do we seek shelter or can we have sex? Do I have good memory connections with sex, or is it something that causes me to have anxiety? And thus my brain goes into protection mode. Does my society or religion teach that there is guilt in sexual expression or engagement? So the brain always has to choose between different drives and motivations. A huge issue in understanding how the whole desire mechanism works is that we don't fully understand how our own hormones and bodies work. We know that dopamine is excitatory and is increased by estrogen mid-cycle, but we also know that serotonin is inhibitory and that estrogen acts as an SSRI, thus resulting in enhanced serotonin functioning, which progesterone also plays a role. But very simplistically, the progesterone changes the serotonin receptor shape. So you can see, I put this here, so you can see there is so much happening inside the brain that we just don't fully understand yet. And then there's the fact that I'm not a sexual response neurobiologist, but I only really study and research the vulvovaginal related health issues. So I don't even 100% fully understand how everything works, but neither do the scientists. The neurobiologists and neuroscientists don't understand how all this works either. As you can see where I just put right there, that estrogen increases dopamine, but estrogen also acts as an SSRI, which then increases the serotonin, which serotonin then is inhibitory and decreases our sex drive. And progesterone changes the shape of the serotonin receptor. So it's all like this revolving ball of what the hell is happening in our brain. It is. It's a revolving ball of what the hell is happening. So HSDD, as I mentioned earlier, was hyposexual desire disorder. So it's desire for and fantasy about sexual activity are chronically or recurrently deficient or absent. This could occur because of a hypofunctioning excitation. So your excitatory system could be malfunctioning, or your inhibitory center and your could be over functioning, right? However, sexual dysfunction is different from HSDD in that a person with sexual dysfunction wants to be sexually active, but physically has difficulties, right? That's the sexual dysfunction. They have physical sexual dysfunction and difficulties, such as arousal abilities or problems with orgasms. HSDD is the desire aspect. You don't have that desire. And so sometimes, not too often, but the data is aware of anyway. It might be happening that the data just isn't aware of because people aren't reporting it. But the data shows that the people with HSDD, for the most part, can still function sexually and physically, or function physically and sexually, where their body responds. They just don't really have the desire for it. Drugs to treat HSDD, I don't know how to say that. Bremelanotide, it's getting late. That stimulates dopamine release. That is on the market. Addyi is also on the market and is a serotonin antagonist, which means it keeps the serotonin low. Still in trials, as you can see, are these other drugs, and what they do. The Lorexis regulates dopamine, serotonin, and norepinephrine. So basically, it's so Lorexis is Wellbutrin, the brand name of Wellbutrin, and trazodone. Libridos is still in trial. It's an anti-anxiety and testosterone. And Librido is testosterone and sildenafil, which I believe is an ED drug, which helps the clitoris tubes, the cavernosus, fill with blood. But that is all I have for this episode. I'm going to pick up Arousal on a different night. And just going over Arousal, that should only be an hour episode because I won't have the general information and desire to go through. So it'll just be Arousal, which is going to be about an hour, and then I will go through Orgasm separately, which will be maybe an hour, probably going to be a little bit less, as there's not as much behind Orgasm as there is in the rest of it. So that might be a little bit less than an hour, and it doesn't look like anybody is going to be asking any questions, so I think I'm just going to wrap things up. If you do come across any questions, just go to healthyhooha.com, use the contact page. That's going to be the easiest way to get a hold of me. For bigger questions, obviously you can reach out to me on any of the social media that I have. I love to help and answer questions, and I love to direct where to find help from specialists and professionals. So make sure to check out the website for new articles. That's it, guys. Thanks so much.